Okay, in the meantime, everyone is coming. Good morning once again to all of you. What we will do is, what was the homework for yesterday? How many of you remember? Yes, group. So, any takers for the groups? What is the group? Has people have found the group? Then we take out a sheet of paper and we can circulate, and then we can put the names in the group. I mean, the groups that they are interested in. So just pass on one sheet. One sheet. Okay, so have we talked to each other or not yet? Yes, no? I can't. No. Okay, so homework is not done.
Sir, done.
It's done.
Done.
By single person. It's a group work. It needs to be done by all of you guys. Okay. So let's take a few minutes to.
Good morning, sir.
Good morning.
Please continue, sir. Good morning, everyone.
So let's take a few minutes to decide on a group. And she is passing a sheet. So the way we are doing is, how many of us are there? Can we count? So 3, 3, 6, 9, 12, 15, 20, roughly around 30 folks are here. 30, 35 are there. So why don't we put group A? So let's take 6, 7 people. So 5 groups will be there, roughly. So let's put A, B, C, D, E groups. So make some spaces and put like group A, group B, like this. And leave a blank for, you can put like this, and then a half page. You can put group A, group B, group C, group D, E, and F, right? Something like that. And people can put their names on it. Okay. So why is this group? So remember that if we put a lot of effort in this, we will have a good work. It's up to us how we want to do it, right? And this is really incredible, as we discussed last time, that in involving ourselves in a research is the best thing you can do in gaining skills of different types quickly. Okay. So what he's doing is he's circulating the sheet of paper. Why don't you guys, are you guys from the same school or different school? Same school. So put yourself name in a different group, not in the same group. Okay. Yes.
Sir, I have researched around 13-14 topics.
Okay.
I will give you share on the WhatsApp group if someone.
Okay. Why don't you?
Rough guide I have made because of lack of the time in the morning.
Fantastic. So this is exactly what I wanted all of you to think about. See, I know he has the experience. Thank you very much. I know he has a lot of experience in the. But when someone is, this is a course to learn, right? To do the research work and to gain skills. You have to be proactive. You know what is proactive? You have to be active in advance. If I say one word, you know how to complete the full sentence. This is how the sharpness in the research comes into picture, and in the job market as well. Okay, so what I expect, so he has done exactly what I was expecting. So what he has done is, he has not only thought about who could be his group members, but also, again, that's a different issue whether I let him do his own group or not. That's a different issue, right? I want to be very diverse group, each one of us, right? In a very diverse group.
Can I share those?
Right. So I'm coming to that. So, and then he has also done the second part, which was thought about potential research things that he can work on. So, okay, go ahead and talk about top 4 of them, or top 3 of them.
So how to present?
Just talk in couple of sentences. What are you thinking about doing as a group project, and if there are any takers. So you are presenting it in a way in 2 or 3 sentences or 4 sentences at the most, so that others can get attracted to work with you in your group also. Okay, so go ahead.
So firstly, there was one topic. It's based on the youth culture that is in India. It's on the social experiment.
Okay.
So it is like that. There is one sibling. They have made a band, but that band doesn't perform rock concerts or like Bollywood or top songs. They perform bhajans. So mostly some of the Gen Z youth, which we say in today's world, they are getting attracted to that bhajans. They are booking tickets and all. And one part of the Gen Z youths are following social influencers and all. So why is this distraction happening? Why are trend shifts happening?
Good.
Then the second topic is basically mostly now. You must have heard now these days it is in news. There are Aravali Hills mining. So government is taking money from the big investors allowing mining, but the people there in Rajasthan, they are protesting against this. So it can be another topic.
But what is the challenge that you are?
Challenge is that if that
The
hills
first
are,
challenge was clear. This one I'm not.
if the hills are cut down, then environmentalists predicted that Delhi can turn into a cold desert. And the second point in this is that the AQI levels in Delhi and around NCR regions will, if that's the cause affecting it can be another reason. And the third reason was about the people of that area, their
Okay.
livelihood and all,
Okay.
environmental concerns.
Okay. So these are good topics to model. Though, again, actually I'm very impressed with the amount of work that you have done and brought some different topics. And these are practical challenges. I really like the topics that he is latest, cutting edge, is impact all of you, even if you live in a different part of the world and not in Rajasthan where Aravali hills are there, or he's talking about Delhi where AQI is very high or something like that. But still, it is a relevant topic of today's affairs, right? So what we could do here is, one thing to remember when you are choosing a topic. I talked about yesterday an example of social problems, right? Social unrest, such as Gen Z, riots in Nepal and Bangladesh, for example. Now, why did I give this example when the course title is on infectious disease and global health? Why is it a really relevant issue? What is the connection with the two? Remember, I'm not going outside the arena of the course topic and title, and I'm still fine with the type topics that he has talked about. First of all, health comes in a very big ways. Health doesn't mean only from diseases. It comes from environment. It comes from other chemicals, right? So he's talking about relevant topics that is really important from the health perspective. That is one point. But that's not the only point. What was your first topic?
There is one sibling. I don't remember the Instagram of them. They are into bhajans. They are making rock band of bhajans. So mostly some of the Gen Z youths are getting attracted towards it, and the other ones they are following big influencers. So
Okay.
what is the distraction? Why is this happening?
So this topic, you all heard it, right? How is it related to diseases that we are modeling? We are
It's
talking-
influencing the mind.
Does it make sense what he's talking about? How is infectious disease spread? How is infectious disease spread? By infection. An infection is spread by one coming in contact with other, coming close contact with other, right? That's how infection is spread. What he's talking about is spread of ideas, information, which is similar, exactly the same way. Does that make sense? So that's why this topic is very relevant, because it is also an infection of social ideas and social views. And that's why yesterday's example that I gave on Gen Z was also relevant, because why did I say about tipping points? The group comes into picture in certain ways that tips off the system. Does that make sense? So social issues are also very much relevant to this fact. Okay. So what I will do is, there is a sheet somewhere. Where is the sheet? Okay. Have you guys written the names? Okay. So also, all of you are from maths department, and some anthropology and some biomedical. Anyone else from a non-math background? All of you are from so mathematics, except these two folks. Okay, that's fine. So the thing I'm thinking about is, once you will write it down, your names in different groups, I will going to ask your skill set. I don't want same skill set people in the same group. I want different skill set people, so that you can complement each other. Okay. So anyway, I'm circulating this. This sheet is, you write down your names and pass it back, and do the same thing. Try from same institution, not to be on the same group. Try. Okay, if it, I mean, we can't guarantee everyone to be to cover in that 6th group. There are 6 groups, so we have now how many folks total are there? You guys know? Where is 45? Physically are here, right? 45. So 45, and so roughly around 7 folks per group will be there, which is decent. So there is 6 group we are aiming for, so 7 folks. So have a seat, have a seat.
The third topic.
Oh, you have a third topic.
I have 13, I have done for 13, but now it's on the third.
But remember, these two are the focus: health and infection process. That is the 2 goal of you to choose the project objective. Now, so today the goal is, we will give you some time in the group projects, and you guys will discuss and think about one of the projects that research objective. Not only topic, but also topic. Forming a group was yesterday's task as a homework, and today's task will be the research objective. So choosing a topic title. Okay. So you will discuss among the group members and see if you can come out in the evening. We will do it, right? And you will have more idea, because I have some example in my slides, and you will see more. Is that okay? Okay.
So the third topic is BHU researchers have found out a plant in the Himalayan region. It's in Hindi it's called Patthar Chatta. So it has an antioxidant which is named as lutein. So they are developing a drug using that antioxidant for the treatment of cancer.
Okay.
Then the last topic is my brother-in-law. He is a doctor in AIIMS Delhi. So he is working in the department of microbiology. So they are working on antimicrobial resistance. Like people today, they take, when they have cold or fever, they take medicines roughly without prescription of doctors. So they are making some research like good bacteria, bad bacteria.
Okay.
So good bacteria dies, and bad bacteria happens to destroy our protein mechanisms and biochemical activities and all. So they are testing gut microbiota. studies, and they are doing metagenomics and
I
all
got it.
those type
So
of.
these are all excellent topics. Thank you for pointing these things. These are relevant in today's world, and we can model it, all of those ones. Again, don't think about how you will write equation at this point. It will come naturally, right? And also I want to stress on this fact that the way we are doing it is not a traditional way of training us. It is a very different way of training. It is about doing it yourself rather than getting a lecture from me on everything. I will give a lecture slowly and slowly in the, as today and tomorrow and day after tomorrow and so on and so forth. But that would be, you have to find a lot of information yourself also. So you have to be proactive on that. So having said that, today we will start with, so what did we cover yesterday, by the way? Tipping points. So what was the title of the lectures that we covered yesterday? What was the first topic we covered? Dr. Dharmendra Tripathi covered what? Bias. And why did he talk about those things? What was the applications for those?
Some basic concept of fluid dynamics.
No, but why is it relevant? Where does it use? What areas do you use it? In health sciences. In health sciences. Drug delivery. Where? Drug delivery in the body, right? You know, you eat painkillers, for example, or you eat some medicine. It goes to the target tissue. How does it go? You have to build the mechanics of the models so that drug travels in a right directions and doesn't get wastage a lot. It always gets wastage, but most of the drugs get targeted in the tissue, affected tissue, and that's one of the very relevant issue of that. What is the other applications of that? What is the other application of this fluid dynamics or concepts of fluid dynamics in health applications?
There are many kinds of biochemical reactions also going on in the body at many parts, and in which fluid is important, its flow, and like you said, drug delivery, composition of drug.
Okay. So you mean to say not only it is going to the target, but how it is interacting with different molecules of the body.
Yeah, and there are many biochemical reactions in different parts of the body is happening.
So where is the fluid dynamics coming into picture?
Yeah, it is very important in that way.
Okay.
It has chemicals.
So the fluid, what do you mean by fluid?
Fluid and gas and liquid.
Right, but you don't have a gas, so you have gas in the body, for example. You have a blood, right? You have a blood, and blood is a medium in which the drug is flowing, or your immune cells are flowing, right? That's how you get. If you get hurt somewhere, all the immune cells jumps to that region. If you understand, not everyone's behave in a different way in terms of immune response. Right? So the fluid dynamics concept also helped in understanding how to improve one's immune response also. Right? So there are biomedical application, a lot of them. It is also used in medical devices. These things, these concepts. So there are lots of application in health sciences. I want to point out some applications. Now, second topic that we did yesterday, so this was first lecture by Dr. Dharmendra Tripathi, right? And then second lecture we talked about what? Professional skills. We talked about professional skills, right? Third topic, model thinking, right? Which was different than, it is very easy for me to give a lecture on models and analysis. It is very easy, but I don't want to give you the same thing that you will learn it in the classroom as a classes. I want to give you something that you will never get exposed. Okay, so now what I will do is, I will talk about today is, so this was the yesterday's part, right? And then we talked about group projects also like a little bit. So we will talk about epidemic math models, and in order for me to give you some ideas, let me give you first of all what is my background. So I graduated in scientific computing from IIT Kanpur. Then I did, I went for a research scholar at Cleveland Clinic, is a hospital chain in US, and I did. I was part of a department of infectious disease there. So I was there for some years. I was also part of a global health department in Case Western Reserve University, which is in Cleveland. And here, actually, I was part of a clinic. Note one thing, I was trained as a mathematician. I had a mathematics PhD. And I am going through this path, which is all medical sciences, after my PhD. And it is my choice that I went to take this path. And it's again, the reason I'm telling you, how did I end up having different types of skill set? So when I was part of this Global Health Case Western Reserve University, I was part of a group which was working on lymphatic filariasis. It's a disease called as elephantitis. Have you heard of elephantitis? Elephant-like legs, or extremities, in fact. Hands and legs. Some people have very big legs, and basically the reason they have this big, because lymphatic system circulates the lymphatic fluids in the body, and in that these patients, these lymphatic glands get spoiled by some insects, some worms, and therefore they cannot able to pump the liquid lymphatic fluids in the body. And so lymphatic fluids get collected in the extremities, and that's why you see big legs and big hands. These people have a lot of problems in doing day-to-day activities. Okay, it's very common. There is in Orissa, in Jharkhand, there are lots of cases of lymphatic filariasis. I worked with Indian Council of Medical Research on this project for some years. But I was working in Papua New Guinea, which is an island country in north of Australia. You know Australia? There's an island country, it's called Papua New Guinea. And why I was there? Because it has the highest prevalent of lymphatic filariasis during that time. And so we were part of a clinical trial. We were distributing medicines free of cost to them. And the hope is that you have the medicine so that if the disease, people get the disease, the medicine is already there in the body to react immediately. And these medicines do not have very slight side effects, so it is very easy to take it. So I was part of this global health, therefore I was part of a clinical trial then. Then I was a faculty at Arizona State University as I was telling, School of Human Evolution and Social Change. This was very interdisciplinary department where it was anthropology, biostatistics, epidemiology, mathematicians, all. There were selected people in one department. So it was very interdisciplinary department. Then I was also at Illinois State University, and I'm still affiliated with them. And I'm now a senior fellow at Kalam Institute of Health Technology, which is in Visakhapatnam. It's, as I was talking about, Medical Devices Park, National Park. It's in it's one of the largest park that I've seen in India on medical devices. Now I also have a company called Kalam Experts. This is in India. And I'm also working some projects in industries, and I have a company in US called America IT, which is, I forgot to list it here. So here I am, this is my hometown, and this is the institute where I work in Illinois. Illinois is the state where Chicago, this is Chicago, and that's where it is, and I live here in Arizona. The city name is Phoenix. So now you know where I am, where I am living right now. And currently I'm working with the two groups. These are modeling group and disease, very famous groups. Pervasive computational epidemiology. If you go on this line, you will see number of projects. We are helping Center for Disease Control in US. So US government is tracking many diseases, influenza. It is tracking vector-borne disease. It is tracking COVID. Naturally, they do it all the time, 24/7. And so we are doing it through that. Another group that I am part of is called VIPRA, Viral Infection Propagation through Air Travel. So how the infection propagates from one country to another through air travel. Note one thing, the infection cannot get traveled in an aircraft. Why? The infection cannot get transmitted in the aircraft. Why is that so? And still, when COVID happens, the infection was going from one country to another. Still, why we cannot have infection in the aircraft? Any ideas? Because it has a very good air circulation system, very, very efficient system. It circulates, cleans the air very fast. When the flight is on the air, it's do the circulation, and that's why you don't feel suffocation in the long flight, even you going intercontinental flights. You don't feel suffocation. It has a very good air circulation system. So in spite of that, there was infection, and during COVID, the whole world got infected. And primarily because of air travel. Because infection happens during boarding and deplaning. When you come out of the aircraft, when you enter the plane, that is the time most of the infection occurs. Transfer of the infection occurs. Okay. So we are looking into this, and we are working with many airports authorities and airlines to talk about this. So this is, go about and check some of these websites. You will see the type of work that we are doing here. Now this is one of the work. It is published in Royal Society Proceedings. It's on high school dropouts. He was my graduate student. He's now a faculty in one of US university. He's very well-known professor in University of Texas, Arlington, in mathematical biology. He's very well-known. His name is Christopher Cripps, and he's also a professor in University of Texas. And this work, even BBC, when we published this work, the BBC had a special show on this work. And this was basically what it was looking for is why do certain schools have a very high dropout rate and certain other schools do not have? What is the reason? And so we did this analysis of, now in infectious disease curriculum, of course, why I'm talking about high school dropout rates? Why is the high school dropout rates relevant here? Because dropout, it's a dynamical modeling, of course it is one thing, but there is other aspects also. Dropout occurs with social influence. People group in itself and influence each other to drop out. The children's we are talking about. And we measure that thing, how much dropout is happening due to social influences. Okay, so, and we did a survey to measure that thing, by the way, in this study. So it is very relevant. Infectious process is happening, but infectious not in terms of a pathogen infection, but a dropout infection is there. Okay. SIAM, Society of Industrial and Applied Mathematics, have an article on this. It's called Silent Outbreak of High School Dropouts. It's published in a SIAM news article. So anyway, and it has a lot of complex bifurcation. Once we designed it, basically it is, there are students who are passing, students who are vulnerable to getting failed, students who are failing, and these out students, already dropout. Do you understand what is dropout? Dropout are people who have left the studies, basically. It happens all the time, right? So that's what we were capturing, and we captured their parents, we captured their social environment in which the dropout students are impacting other students to drop out. So it is not the influence always happens in a positive way. Sometimes encouragement happens in a positive way, but also negative things happen. And dropout is a negative influence that we are talking about. Okay. I have another work that is published a long time back. It's in PLOS 1, and it's on mass shootings. You know, in US it is very common, mass shooting is very common. You know what is mass shooting? Like someone with a gun shoots in a mass and kills or injures many people. So it is a big problem in the developed world. So we studied using models to understand this mass shooting phenomenon. Why is this happening? So this work actually still very highly cited work, one of our very highly cited work. And there is a show by, do you know him? Morgan Freeman, right? Very famous actor. And he does this show called as Through the Wormhole. Through the Wormhole is the name of the show. And so they have one episode of, so they bring different problems from the life. And one of the problem was mass shooting in his show. It's a scientific show basically, Through the Wormhole. Very old show basically. And they have interviewed us. We have one episode through the Wormhole only on mass shooting where our research is being used. Okay. And why is this important for us here? Why is it important for us here? Because what we were looking here was how is this one incident of mass shooting influencing the next occurrence of the mass shooting? Because what happens is, just like when any incident like this happens, it is all over the news, everywhere. So there are good people who are very, good people who are making now more stricter policy on gun control. But there are people who are vulnerable or who are mentally unstable. They are getting more influenced by doing these type of events. So it has these science aware, these news are making people aware of the news, but at the same time it is a disadvantage that the people who are vulnerable and can do such type of incidents are getting more influenced by that event. Does that make sense? So that is what we were capturing here. What is the likelihood that the next event, by the occurrence of this one event, will occur? So we captured that intensity of the event. Okay. And so what we did is, now one thing more, these events, the big problem here is they are not, you can't find the data. There is no data for that. So what we did was we looked into last 10 years of newspapers in the library, and we used some news agencies data also to make and extracted all the details of the mass shooting that has occurred in the last, in which 4 or above number of people have died. Okay, and then we basically made the data from scratch, and then we used the models to estimate the parameters. So exactly the topic that, so why I'm exposing these examples? Because it helps you think about your own research project that we are talking about. Now, infectious disease, let me come back to the infectious disease, has many years of, is there any disease occurring right now in India? Is there any outbreak, epidemic that is occurring in India? Anyone knows about it? You have not heard in the news, right?
Recently in Lahore, Pakistan,
Yeah.
there's 3
Pakistan.
influenza.
Okay. Say it again. Some flu,
Yes, some flu is there.
monkey flu. Is that what you say? What is it? Monkey? Okay. Well, there are thousands of outbreaks that are going on right now. Thousands, if not less. Not every outbreak you come to know in the news, or the only news outbreak you come to know are the big ones. But there are always happening the local outbreaks all the time. There could be rotavirus outbreak. Rotavirus is the babies getting diarrhea. It happens all the time in local villages at a very small scale, right? When you work for a public health department, then you get to know these things. But otherwise, in the news, you only get a national level news, right? Or something. So there are lots of outbreaks that happens all the time, and that's the reason you have public health department in every small regions. You know, there is a regional, then there is a state, right? So state has a health department, and then region has other health units of the health department, and they track all these things. So this is an example of some of the major outbreak in the world. You may not have heard about it. So, have you heard of Spanish flu? How many of you have heard of Spanish flu? Black Death was different. Black Death was not in this century. This is only starting from in the 20th century that I am talking about. So it is 1900 that we are capturing in this picture. But there were other. So Spanish flu, there is a hand there. So what have you heard about Spanish flu?
Just the name, nothing else.
The research paper.
Research paper. So why is it a big thing about the Spanish flu? How many people died? Did you know? Any outbreak? It was all over the world, maximum part of the world. And how many people died? It's the largest outbreak known to the humans that is documented. How many people died? 50 million. Sorry. Okay, I should have typed that. Okay, so there are 50 million people. A lot of people died. That's a lot of people. 50 million is a lot of big number. What is how many millions of people are in Delhi? Delhi metropolitan area, let's say. If you take a metropolitan, it will be around a little less than 18 million or something, 20 million. But if you talk about Delhi only, it will be like 9, something like that, around that. So roughly around 19 million people in metropolitan, big metropolitan area. So think about 50 million people. So many people, right? So Spanish flu is one of the major ones. West Nile virus, Ebola virus. Have you heard of Ebola outbreak? Recently Ebola outbreak. HIV. Everyone knows HIV, right? Is it still an outbreak?
It's ongoing.
Okay, so this is ongoing. But there are so many other viruses that you have not even heard about, right? So outbreaks is happening all the times and maybe simultaneously occurring. Measles outbreak is going on in the US. So they are stopping people from going to the Disneyland, for example, because children are getting measles infections, right? So I'm just giving some examples. Coronavirus, there was another coronavirus. COVID was coronavirus that occurred in 2012, 2013. You guys don't know about it. Not many people died, but it was localized outbreak. It was not global. COVID became a global. When it is a global outbreak, what do you call? What is the name you give? Pandemic. Pandemic. When it is spread globally, it is called pandemic. Right? Epidemic is a small scale. The terms are very important also. Okay, this is now from a modeling perspective, it has huge history. What we relate to the modeling goes back to John Grant, which is in 1620, the first model that we talk about. What do you think? What is the guesswork that you can make? What is the model that he did, John Grant? Any idea? What is the model means for him at that time? There was no dynamical system, differential equations that he was writing. Right? At that time the model means, so basically at that time they used to publish all the deaths without telling what is the reason for that. What he did was he categorized the deaths based on types, from water due to drinking water, due to poisoning. He categorized the different tables, and that was the model. So the model was tabulated in a certain categories. What does model means? That it is simplifying to me things that is very complex in reality. So, it's not always when many equation you write that is the best model. The model meaning is different. Writing something that makes people understand things in a simpler way, that is the model. Okay. From there's lots of many types of, for example, Bernoulli's work was on smallpox. Smallpox was also, there's one disease that is eliminated completely from the world, which is? Say it again? Human disease. Which human disease has been eradicated from the world? I'm sorry? I can't hear you guys. Louder. It's a smallpox. That's the only disease that has been wiped out. It's there, but it is there in a lab, in a couple of labs, in Russia and in US. Okay, so there is, it's not, the pathogen is not circulating in the population. It has been eradicated. And only smallpox is the only human disease that has been eradicated. There is no other disease so far that we are aware of. There is many animal disease that has been eradicated, but human diseases are only smallpox. Now there are different types of work. These are all important people who have added some features to the modeling work. For example, rate of contact by Hammer. He described rate of contacts. He described how to write the rate, how to estimate rate of contact in a very simple way. But that is now what we use it so casually. But these are the people who are pioneer in identifying some features of the models that we use today. Sir Ronald Ross, how many of you have heard of that? He was the first one to model diseases through vectors. What is vectors? Through insects, for example. In this case, insect. He was the first one. In 1908, he got a Nobel Prize for describing the life cycle of the malaria. Life cycle of the malaria means the pathogen in the malaria goes and spends some time in mosquito and sometimes in mammalian host. So there is a cycle there, right? Half life in the vector and half life, not half, but some life in the human host. And that is what he described. Before that, nobody knew why we are getting malaria. They think it is through the infection from coughing someone, right? That's what the people used to think. But now we know mosquito can infect us also. There is other disease, Kala Jwar. Have you heard of that disease? Who is from Bihar? Anyone from Bihar? So have you not heard of Kala?
Yes, sir.
Right. So what is that?
It is a type of illness of mind.
Okay.
Basically, it is a high fever.
High fever, right? High fever, and it could cause mental issues as well. But how is it transmitted?
From any insect or Any type of
Not any insect, especially one insect, which is sandflies. It is called sandflies. And in Bihar, in Odisha, in Jharkhand, it is very high incidence in certain. So, and I worked with there at in Bihar at Rajendra Memorial Institute of Medical Sciences on this thing for a state health department. So, have a seat, have a seat. So, so leishmaniasis, it is called Kala Jwar in India. In English, it's called leishmaniasis. And so, Ronald Ross was not a mathematician. Was not a mathematician. He was a doctor, physician. All the mathematical things that we use, which are practical today, most of them are somehow discovered by non-mathematicians. Practical aspect. So the models that we use for malarias are is his two students, Kermack and McKendrick. You know about Kermack and McKendrick? Right. So, well, SAR was already established before that. It was not. So it was a reproduction number that was Kermack and McKendrick. This was in 1927. These two were the students of Sir Ronald Ross, and they basically, expanded the theory of infectious disease modeling that we do today, basically. And this is around 1920. This is a very pioneer work. It's the tipping point that we were talking about was discovered during that time. Nobody knew for a long period of time until very late. Okay, so this is early 20th century, 1930s, around end. Now this is latest. This is the latest till 2020. Now I want to say this is the first simple model, John Grant, that I am talking about. But also Ronald Ross, 1902, and then there is a gap because I don't want to show everything. Very important, 2002, there was a foot-mouth disease outbreak. Have you heard about that outbreak? It happened in UK. This happens in kettles. So there was farmlands, and this infection was spreading in kettles. Kettles, you know kettles, right? And because this infection was spreading, they have to kill a lot of animals. So there was a huge loss to the farmers. So it became a big issue when the UK were, very dominant at that time in 2002. So there was a lot of modeling work that came forward during that time. It's actually new pioneer work that started around that time. Also there was 9/11. Do you know 9/11, right? 9/11 was the Twin Tower was attacked in US, right? During that time there was multiple things happened. There was anthrax attack. Anthrax was also an infection that was sent to people in an envelope. And when they opened the envelope, they got infected, right? Although it didn't become a big outbreak because it was controlled. So at that time, this is a time when modeling work start to pick up. Why? Because US government was already struggling with 9/11 because they were afraid. Then there was disease attack, and then they were seeing foot-mouth outbreak in UK. So they were very afraid about all these things. So they established a task force. Why I'm talking about US? Because that led to the lot of publications, lot of work that we use as a reference today, modeling work. So 2005 there was a task force that was established by the US government, which has anthropologists, which has biostatisticians, which has mathematicians, which has physicists. It was many different fields in one task force. And their goal was to handle the infection or the risk associated with the infections. So they started doing novel innovation and research work. Task force was pumping a lot of money. But money lead to more research and innovations also. So, and therefore, the Spanish flu that we discussed just now, nobody knows about Spanish flu until 2010. When this task force starts to publish a lot of papers, then we realize about Spanish flu. In fact, we didn't know what is the virus that is infecting Spanish flu. When Spanish flu was spreading in 1918, nobody knows that it is a virus. They used to think it is a bacteria. Nobody knows that time. Until 1950s that they realized there is a virus also. And that which virus was the influential in Spanish flu was identified during 2005 and 2010. Very late. We came to know about Spanish flu in 2010, literally. And there was lots of modeling work during this time. And so then it started, see, this is the what is biosurveillance and preparedness task force. This is what 9/11 anthrax. There was actually COVID-1. COVID-1 during this time also, coronavirus 1. What we saw was very late, different types of coronavirus. Okay, studied 1918 flu. So this is the time, 2005 to 10, there's number of papers on modeling work, mathematical epidemic modeling. Then came influenza forecasting. So influenza is something that impacts us everywhere. We all get cold symptoms. You know, we don't care in India, but in in Western world they have models to forecast when there will be infections, how many cases, and there are vaccines also for that. So that is started in 2013 onwards, and then there is a Ebola and Zika virus. I don't know if you guys know these things. Ebola and Zika were big news during that time, in 2015 onwards, around 15. So there was this thing. And then there are ensemble model. Ensemble, you know what an ensemble means? It's a collection of many models, not one model for outbreak. The researchers are making many group of models, and because one model was not doing a good job, so they needed a different types of assumptions, different models, and take the results as an aggregated result, and they called it as an ensemble model forecast. CDC nowadays practice this thing. In fact, all of the organizations which are health institutions doesn't take one model, but take a collection of models. Okay, so that was the history that gives us a beautiful pictures about how things have evolved in the modeling world. Weather forecasting, we do it very good. Why can't we do infectious disease modeling forecasting? Very good. Weather forecasting, do you get the weather, right? You check the weather before going to the certain place, and it can tell you precisely for 7 days forecast. But you can't get it they don't have any app for infectious disease. Why not? There's a problem. What are the problems? Data is one thing. And what is the problem with the data?
Like, maybe manipulatedly, the people who are reporting it.
Okay, people are reporting it, right? Wherever how is the data for weather is collected? By machines. There are machines at different places. They talk about wind, they talk about temperature. There's no humans involved there, right? Wherever humans starts to come into pictures, things become messy. So the data is a big issue. He's absolutely correct. We don't have a consistent collection of data from every angle. Or if it is collected, it has a lot of issues with the data. It is polluted data, polluted in some sense, right? Also issue is human behaviors. Human behavior is not consistent. It changes. Why behavior is important in disease? Because think about that. If everyone during COVID times have stayed back home, did COVID have a spread? No. Since we changed our behavior, either we were taking more risky behavior based on our knowledge of diseases, we were doing sometimes assisting in spreading of infection. So human behaviors are not consistent, and everyone is taking its action individually. So there's a lot of complexities involved in human behaviors, right? That's the reason diseases are never able to be tracked as you can track weather, right? Other things, yesterday someone was talking about one more important factor. What is that important factor in diseases? evolution, right? Strains, different infection strain evolve. We don't know how the strain will multiply and become more infectious or less infectious, or which region it will go. Does that make sense? So the evolution of the strains we don't understand. There are not established models for that. Okay, so that's the distinction that makes it very hard for us to really do the same thing what we can do with epidemic models. In diseases, what do we answer? What type of work we answer? We answer things about vaccine, which age group we should give vaccine, whether there will be a delay of 10 days in giving vaccine, how much impact it will do to the society, so on and so forth, related to vaccine. Diseases on therapeutics mean drugs. These are the questions we ask. What type of drugs we should promote by government, what we should not, because government doesn't have infinite amount of money. It's always resources are limited. So where should you focus? If you have 100 rupees, what is the cutoff of the age group in which you should give vaccine? You can't give vaccine to everyone because there's no infinite amount of money. I wish, but we don't, right? So these are the issues that we answer through the models. Okay. What's the time? 10:15. What time is the break? Do we have an idea?
11:15.
Say again?
11:15.
11:15. Okay, so we have some time. So microparasite and macroparasites. Micro is viruses, protozoa, bacteria. Macroparasites are helminths. What is the difference? Why are we dividing into these two things? Because the models of microparasite and models of macroparasite are very different. Different models we do, different types of equations we write. This is the difference. Average lifespan is shorter in microparasites. They last for few days only. Macroparasites could be few years. Example is worms. You know, guinea worms. The Pilaris is also worm. These are worms. Worms, you know worms, right? These are worms. Whereas these are viruses, protozoa, bacteria formed in the microparasite. Other issues is, this is one of the important issues, this one. Parasite. These multiply very small amount in microparasites in a small amount in the human host. Whereas macroparasites, some hosts have very few of the infections, some other hosts have a lot of parasites. It's a lot of variation in the parasite count inside the body of an infected person. So macroparasites has a lot of variation of number of count of the pathogen inside the body. Okay, why is this important? Because you will see it in few minutes. Also, one important thing is, how is this thing spread? How is virus spread? By cough, cold, right? Direct contact. Direct. But helminths or macroparasite cannot be spread directly. They need another one, such as food. So they need snails. For example, snail is a animal and they live in water. So they can also transfer certain health worms. So they need another insects to transfer. So basically these pathogens have some life in the human host and some life in the non-human host. Okay, so this is very, very important, and because of that the models are different in microparasite and macroparasite. Do you understand these compartments? Anyone have seen this? So in microparasite, in virus diseases or bacteria disease, we model it as the population. We are modeling it in this group. We have susceptible people, we have infected people. S stands for susceptible, I stands for infected. So that's a susceptible and infected. This is a microparasite, viruses and bacteria. But in macroparasites, you don't talk about susceptible and infected. You talk about number of pathogens in the human host. The quantity of infection that you are counting. You're not counting number of people who are infected. You're counting amount of infection in the person. Average amount of infection in the person. You see the distinction? That's the distinction. We do have to model it very differently. Okay. But there are also model of co-infection where you have both microparasite and macroparasite infected in the same human host. For example, lymphatic filariasis patients are infected with the flu. So then there is the co-infection cases. Okay. Okay, so how do we model? Model is bookkeeping exercise. I think many of these things you might know, but bear with me because this is important for me to continue in a fluid way. So it's a bookkeeping exercise. So basically it's counting at different time points how many these geese are there, for example, or this here's is a type of a cat, a wild cat. So you count the basically, and this is a bookkeeping exercise. Bookkeeping is you are noting down the number at different time points, right? So the way you model, if you want to know how many, what is the population in next time step, you take number of people in the current time step, you add the number of births, subtract number of deaths, immigration, how many moved to this region, how many moved out of this regions, and that's the total count of today's, right, based on the last time step, right? That's how we count. That's a bookkeeping exercise. It's like noting down level of the water or amount of the water in the container, where you have a tap, two taps which is feeding inside and two taps leaking out, and you are counting how amount of water in the bucket. Okay, that's the same phenomena. And in ecology you do it in sustainability, you do it in, you name the field and you do the same thing everywhere. Nothing different. And this is the model. And the model is about how do you capture birth, how do you capture death, how do you capture these four terms. Now this could be captured in a different functional form, different types of functions. So diseases are modeled using compartment, simple compartment, susceptible, infectious, recovered, and there is this term makes diseases as called as infectious process. Infectious process. Same way as influential process that I was showing an example before, like dropouts, like mass killings, right? This things makes it different than a chronic diseases like oncology. Cancer is a chronic disease. Diabetes is a chronic disease. It's not infectious disease. Okay? So this is the term what makes it an infectious process. And it is the interaction. I comes in contact with S, and that result in people moving from susceptible box to infected box. Okay. And again, it's a bookkeeping exercise. How many in the current time, how many left, and how many are there in each of the boxes. So the transmission is this process of this going from S to I. And it depends on multiple factors. It depends on host population size, it depends on contact rates, it depends on pathogen infectivity. Contact rate. What does contact rate mean? What does contact rate mean? Okay. Do you think it is everywhere the same? What should it depend on? Population. So it depends on the density of the population, right? Okay. So the contact rate, and it is not static, it depends on behavior of the population also, cultural issues. It can depend on many different factors. Why I'm saying there are certain religious aspects that covers your whole body, more less likely to have this. You can't define the contacts the same way as we are defining contacts here, for example. Right? So this people spend the whole dissertation in measuring contact rate. I've seen at least 2 dissertations on that. And it is a lot of, and think about that. If we are talking about viruses, okay, fine, this way. What about that which is like flu? It's a human to human. But what about if it is, what about latecomers have to buy dinner for everyone? So what about mosquito-borne diseases? It's not the same contact anymore. Is the contact with the mosquito now important, not human to human contact? So there you have to measure it in a different way. Also, issue with the mosquito is that mosquito feed on certain people more than others. They like some more blood better than others. They have their favorites also. So there are these issues that plays very important role in measuring these, estimating these contact rates. Okay, so there are lots of complexity that involves this thing. The modeling is about how do you model these terms. That's it about modeling. Is writing compartments, writing equations is not difficult. How do you choose these terms are the most skills that is required. So these are is a bookkeeping exercise. Basically, this is minus. That means people going out of it due to interaction of I and S. They are leaking. The susceptible people are changing. ds by dt is rate of change, right? And di by dt is rate of change for I. dr by dt is R means recovered. People who were having infection before but not having infection now. Have you guys seen this model before this type? How many have not seen it? Never seen this type of model as I have. Everyone has seen it. Everyone has seen it. Yep. Okay, good. So then I can go very quickly. So then basically if you plot this thing, you get this outbreak. This is an outbreak, right? And this is what, is this model good for COVID? No? Why not? He's saying no. So why? Why this model is not good for it?
They can go back to brain.
Mutations.
And the incubation period.
So I think you guys are going way deep into the things. But what I'm saying, if you see the number of cases in a town, it is going like this. And this model is only doing one peak, right? So this model is good only for one peak, but not for everything, right? So answer is correct. I mean, there could be many epidemiological reasoning that could cause these fluctuations to happen. Okay. So this model is you need that, but this is not sufficient. You have to add more terms. Remember in this previous slide, you added these terms. So these are, so there could be other reasons why people can come from other areas. Reproduction number is a tipping point of the infection. Yesterday we discussed about it. It's basically the ratio of, so we are capturing, this I is important, number of count of infection. How many coming in and how many going out. This ratio is called as reproduction number. Right? So this is a bucket. This is a bucket. A tap is filling in and tap is leaking out. So how many infections are there depends on this ratio. If it is equal to 1, if it is less than 1, the disease dies out. If it is greater than 1, this ratio is greater than 1, that means one infected person is replacing more than one, him or herself. right? Then there will be an outbreak, and that's what it means here. So there is an outbreak. If R naught is greater than 1, this is peak, and if it is R naught, it decreases, goes to 0. So this is a tipping point. The tipping point is R naught equal to 1. And what is R naught? Is the ratio of what is coming in and ratio divided by what is going out. Right? I mean, if you have some box here, something is coming in and something is leaking out. So how many is there? Depends on what is how much is ratio of this versus this, and that's what it is. Why is it important? It is important not because only it is a tipping point, but it also gives the features of various things. For example, if R naught is 10, very high number, then you will get a peak, faster peak, very quickly peak, and then slowly going up. Whereas if R naught is small, number of peaks slows down. I mean, it occurs lower peak and on the right, two features. Which one is better? Which one is better? The fourth one, R naught equal to 2. Why is it better? Why is it better?
It gives time for the agencies to get the interventions.
Yeah, not answer from you. You are talking in different language. My question is, why it is better for you to have a smaller R naught than the bigger R naught?
The infection rate is lesser. This is easily controlled. As I said, we can give the treatment better, the better way.
But this is not about treatment, because this is not, it is at the population level.
The number of infections are also less.
It will become controlled.
Right. The number of infections low. So one thing to note is, I think he mentioned this thing in the first sentence what you saw. One of the important thing here is, you have limited resources, limited number of hospitals. There are limited number of beds. If there are 100 beds and you get 1,000 infected cases, what will you do? People will have to die outside the hospital, right? And that is the main important point of the disease model. It helps you. So this one is better. Why? Because first of all, on a single day, the highest number of people, this peak, is lower than the number of people. So on a single day, if you go vertically up, the peak is smaller for this number, R naught, right? So that means the maximum number of people on a given day will be about this. So this is lower. So any number of resources can handle it, if your resources are within that boundary. But if your number of beds are around this level, then this number you will have more infected people, right? Does that make sense? So the capacity, not only that, also what this reproduction number is doing is it's shifting to the right. It's slowing down the epidemic. You will still have the cases, you will still have the infection in the community, but it is slowing down, it is letting you handle the situation better of the number of cases, right? That is the benefit of these model. It tells you what a R naught is, and it can let you tell how could you reduce the R naught by different interventions. If you reduce the R naught, you will shift the epidemics, you slow down the epidemic. And that way you can handle with the limited resources that you have. Limited number of hospitals, limited number of physicians, limited number of nurses, limited number of machines, medical machines, you can handle with that. Otherwise, if all the cases occurs in the same day, you cannot handle. Why you don't have a huge amount of hospital? Because resources are limited. You keep just bare minimum to handle the situations of day-to-day cases, which is normal. But if it is an outbreak, lot of cases, then things get overwhelmed. So that's the benefit of reproduction number. Okay. There's a word we use is mechanisms. 11:15 is a break, right? Or what time is the break? 11:15. I think it's a long time. So, mechanism. What is mechanism? Mechanisms. So, for example, if this is a transmission rate from S to I, people are getting infected from S to I. What is the mechanism means here? How things are transmitted. Is all disease are modeled in the same way as transmission for the transmission rate? The answer is no. Malaria is modeled in a different way versus flu is modeled in a different way from a transmission rate perspective. It's different. So there is a way to model like beta times S. There is no I in it. There is no number of I. Only beta S. This is called initial exponential I. This is good. This type of modeling is good for transmission rate. It is good for diseases in the initial stage when the disease is increasing exponentially. This is good. This mechanism will not work if the disease is stabilizing and you have reached to the stable state, right? Because disease never always keep on rising. At some point of time it starts to saturate. So if it has reached there, this type of infection is better. Transmission rate is better. And if there is a population behaviors are involved, then this type of infection is better. This is called as a mechanism building. This type of process of choosing a right time type of terms is called mechanism building. We are building a mechanism in this how the disease is spread. So there is a word we use called dynamics. All are mathematicians. What does dynamics means? Who can explain me what is dynamics? Are you sure? Are you sure about that? It is more than that. It's not only time. There is a word we use in statistics called as time series that changes in time. Why don't they call it as a dynamics there? You get I counter your statement. I'm giving a counter example. I'm giving an example that in a time series models, they don't call it as dynamics series. They call it as a time series and it fluctuates like this. Why do they not call it as dynamics then? If it is a time changing.
Its characteristics or features also changes.
Continuous change, evolution.
Well, that happens in the time series.
Population.
No,
But we capture a, like, it is discrete. This is data. That is data. From time mix we also get a image. It is also time series, trajectory. This is time series data, like so.
Well, it is.
It is like when a force acts on something and if it changes.
So it is exactly. All of you are saying it right, but it is more to just time change. It is not only time change, but it is a weaving. Weaving one factor influence other. Other factors influence the first one. And that weaving back and forth of the compartments is called as a dynamics. That results in the dynamics. So, for example, you see in each time step, you will compute beta, S and I, right? And that time step will, in fact, will result in people who are change in the count of I. And that count of I will change the recovery rate, right? So it is weaving back and forth different terms. Weaving, do you know what is the word weaving? Have you seen your moms weaving the sweater? Right? It's the same type of idea. Each of the component or mechanisms are impacting the other components, and that is making things dynamic in nature. So, okay, I already talked about it. Reproduction numbers. This is the reproduction numbers. For measles, it is a very high reproduction number. For measles, it is very high reproduction number. For it's around 17. Influenza, it is 2. Chickenpox is 7. So that means measles can spread much faster in the population in general. Have you guys seen a movie called Contagion? Have you seen a movie called Contagion? Or have heard about it? Yes, no? Okay, you should see that. These people are actors and they are talking very technical. People don't know these things, but these actors are have did huge amount of research to talk very in technical way. Kate Winslet, you know Kate Winslet, Titanic? Have you seen the Titanic or have heard about? There was an actress, Kate Winslet is there in this movie. So let's see what is this. There is possibility of the speaker. Possibility of the speaker. Oh, we can put a microphone. Can you hear or no? Can you hear or no? It's not possible. Let's have a let's try it again, and you have to all hear it very. So we should not talk actually, otherwise it'll. Okay.
What's that? It refers to transmission of surfaces. The average person touches their face 2 or 3,000 times a day. 2 or 3,000 times a day. 3 to 5 times every year. In between, we're touching doorknobs, water fountains, elevator buttons, and each other. Those things become fomites.
This is something we want to release to the press for specific moment.
And how's the public going to react to that? It's hard to say. Nazi shark in the movie will keep you from getting in the ocean, but a warning on the side of a pack of cigarettes. We're going to need to walk this over the face before we start to figure everybody out. I mean, we can't even tell people right now what they should be afraid of. We tried that with swine flu and all we did is get healthy people scared. It's the biggest shopping weekend of the year. And who's facing the kids? People that work at stores, government workers, people that work in hospitals. When will you know what it is? What causes it? What cures it? Things that keep people calm. What we need to determine is this. For every person who gets sick, how many other people get it? So, for seasonal flu, that's usually about 1. Smallpox, on the other hand, is over 3. Now, before we had vaccine, polio spread at a rate between 4 and 6. Now, we call that number the R naught. R stands for the reproductive rate of the virus.
Any ideas what that might be for this?
How fast it multiplies depends on a variety of factors. The incubation period, how long a person is contagious. Sometimes people can be contagious without even having symptoms. We need to know that too. And we need to know how big the population of people susceptible to the virus might be. So far, that appears to be everyone with hands, a mouth, and a nose. Once we know the R naught, we'll be able to get a handle on the scale of the epidemic. So it's an epidemic now. An epidemic of what?
We sent samples to the CDC.
In 72 hours, we'll know what it is. We're lucky. Clearly, we're not lucky.
Okay, I don't know if you guys can hear, but this is really incredible. type of work um, that this movie talks about. And okay, so once you have this model designed, the next step is to know these estimates of the parameter. That is very, very important. So then the question comes, how do you estimate? So what do we do? What is these dots? Dots are the data that comes from surveillance, from public health departments. And it tells you over time how many cases are occurring. How many number of cases on day 50, for example. Those dots represent each time point, how many cases are there. So your goal of the model is to get the, choose beta and gamma. So basically, in this model, there's two parameters, beta and gamma, right? Your goal is to find out what is my beta and gamma that fits that curve to the all the data points better, best one. So basically, so this is the data, and you are fitting this is a model from eye compartment, right? That's what the shape was looking like. And you are trying to fit it, and you are trying to find what is my beta and gamma. Beta is on this axis and gamma on this side. What is my beta and gamma that fits the range at which this curves fit the most of the data point. That's the goal, and that is what we do most of the time. And it's very complicated task, very, very complicated task to do something like that. Yogesh, have you done anything on estimation?
Recently, sir, I'm working on a side project and we have done estimation with the help of ABC and SMC.
Okay. And you are using which method?
ABC and SMC.
Okay, so going further, once you have the estimate, now you have to think about what does my disease look like, and disease biology decide which model to use. So first let's look at this, or look at this one first. SEI means exposed class. There are diseases which needs some times before they people get infectious in this. Can you give me an example? What is the disease that can be captured by this model, SEI? Okay, TB could be the one. There are lots of diseases. Flu also. You don't become infectious the day you get pathogens, right? You become infectious after 2-3 days. So flu is also. But is the flu model good for this this type of? Why not? Recovered classes is important. There is no recovered class. HIV. Once you are infected for life. So this is the best model for that. Very good. Thank you. Which model is good for, which disease is good for this one? SEI, so what is it? SIR-S. What does S means? That means again you become susceptible. What disease is this?
COVID-19.
Common cold. You can get multiple times. There are many diseases by the way. What about this one? SIS. You have to think about. Okay. But what it is helping us think about different disease lets you choose different boxes and different arrows. And disease characteristics tells you which of these figures to choose. What about this one? This has T as a, I'm using as a treatment class. Right? If your question is about disease trajectory, these models are fine. But if the question is about treatment also, there is a treatment. There are many diseases for which treatments are not there. Right? So you want to model this way. But if there is a treatment available, then you want to, and the research question is about treatment, you want to, you just don't build a compartment without any reasons. Every compartment has to have a reason why you have built it. Okay. What about this disease, birth and death? Where do you use birth and death and where do you not use birth and death? Give me an example of a disease where you will not use birth and death. What short time? Short time is what? infectious period, or even the infection process. Yes, Yogi.
For example,
Right. So,
Sir, viral fever. Viral fever.
yeah, so flu. If you're talking about flu, viral fever is what? Virus has to be influenza virus probably. Or maybe some other type of virus. So that is, you will need birth and death, or you will not need. Not need. Why? What is birth and death? How many years a person lives? 60, 70 on an average, at least, right? And what is the incubation, what is the infectious period, or what is the life person remain infected in the flu? 10 days as compared to 70 years. 10 days as compared to 70 years. If the duration of infection is very short, you don't put the demography, which is birth and death. If it is long, so where do you put birth and death then? Give me an example of a disease. Tuberculosis, long disease. Few years it takes. Well, cancer is not infection. I'm talking about infection. Right? HIV. Right? There are many diseases. Malaria. All of these diseases. Well, malaria is depends actually. Depends on what you are modeling in that. Okay. This is a very beautiful way of seeing. This is from some book actually that I got this picture, and what it is showing. If you model as two compartment, S and I, the shape of I compartment, it will be looking like this. What is it showing? Saturation. It increases exponentially and then saturates. Shape of I. So box I over time will look like this. If you have S, I and R, recovered compartment, then you will have a peak and dies out. If you have birth and death, then you would fluctuate. Okay, so why is this important? Because it tells me what model to choose. So if I am seeing the actual real life data which is fluctuating, I would not probably choose this model or this model. So it is a backward engineering, looking at the data and then deciding which model to use. Does that make sense? So this is where is also you one need to decide. Not only disease decides what model to use, but also data decide which model to use. Does that make sense? Okay. What is the data sources we are using for that? Well, we are using surveillance data. We are using electronic medical records. I think someone will be talking about electronic medical records in the last day, right? And other is epidemiological studies. These are the, what is surveillance data? What does surveillance data mean? What does surveillance means?
Sir, community medicine based data. They do
Well,
the
how is it collected? How is it collected, surveillance?
So basically they organize camps and from that they collect patient history and all those things.
Well, that is an epidemiological study. That is epidemiological data because that's a focused small population. But what is surveillance? What is surveillance? And surveillance is ongoing process, never stops. It keep on going.
Health department.
Health department does it.
Like big institutions like ICMR, DBT.
Yeah, so Ministry of Health does it. So there is a Ministry of Health which is central government. Then there is a state government health department, and every state has district, or not, a state has regions. Each region has health departments. Each region has districts. Districts has blocks, and blocks has villages. So there are different categories of health departments that is feeding the data upward. And that is called as a surveillance, and it is an ongoing. It is going on for mortalities, it is going on for infections of different diseases, it is going on collecting all the time. And that is the surveillance data. Now, so what is electronic medical records? Can you explain me very quickly so that everyone can understand?
Yeah, I'm working in the Friends database. Like if there is a system, like there is a platform.
How is it collected? That's what I mean.
Like every hospital has portal.
Okay. So hospital has a certain way to, when a patient goes there, hospital collects the information.
Yeah.
What is that information includes?
All information like demographic information.
Demographic, birth date, which location the person is coming from, what is the gender, right?
Yeah.
Maybe other things, socioeconomic conditions, something like that. What else?
Purpose of hospital visit.
Purpose of visit. The reason you will visit to the hospital is not for vacation, right? You're visiting hospital for some symptoms, for treatment, right? Some kind of issues there. So those symptoms. What else?
Date of entry, date of exit, how many days they are staying here, how in which ward.
Correct. What type of treatment, what type of diagnostic a patient has gone through. These all records are saved in the hospital setting, and that is called as electronic health records. What is the difference between health records and medical records? You know?
I think medical records.
So health records contain your socio-economic aspects also. Because health could be impacted by many other factors. Medical record is related to just by medicines related. It could be drug, it could be symptoms, it could be vaccine, all those things. Health could be in more broader scale. Okay. These records are not easy to get because these are privacy concerned. You can't just give the records of someone's health related to just. So it is a lot of difficulty, and you should talk about some. He will be talking about some challenges in getting that data as well. Okay. So those are the data, and epidemiological studies are done by researchers, individual studies. Those are local. There were specific populations for which they are. So these are very different type of studies from which the data is collected. This is an example of a model that is capturing hepatitis C. Have you heard of hepatitis C? Virus? It's a viral disease, right? And hepatitis C, and this is actual published work, the goal of this work was, there's a treatment called as direct acting retrovirals. Retrovirals are the treatment that are given to some virus disease. For HIV also, retrovirals are given. Basically, what it was saying, this is a liver disease. Hepatitis C is a liver disease. Liver stops functioning the way it is supposed to function, right? So there are different stages of liver, and before it fits. So these are stages of the liver: first stage, second stage, third stage, and eventually the liver stops working. So we are capturing this disease in different stages of the liver. In number of infected people in each type of liver stage. There are 5 stages of the liver, and after that, liver stops working. Okay, so, but what it is capturing is infection process. And why is it has many stages of the liver? There are people in this stage, there are people in this stage, there are people in this stage, and so on. So, why there are many stages of the liver that we are putting? Because we were interested in the treatment, expanding the treatment. So typically, the treatment, the guideline says the treatment is only given to these 2 set of people, not to all the stages, not to initial stages of the liver. Only at the last 2 stages, the treatment is given. That's the guidelines, government guidelines. But now what we were aiming to expand it to the other 2 stages also, the earlier stages. And we wanted to see, is it beneficial to do it, or we are just wasting money, too much money? And it is not improving the outbreak situation of hepatitis C. So that was the part, and we did this work. So this has a dynamic model for the disease, but then it has economic models also. It has economic models for cost of expanding. So it has economic model, it has a disease model, on top of it is an economic model, and top of it is an intervention model. What type of intervention? So there's 3 layers of different models, and they are feeding back and forth into each other. This is another model on HIV/AIDS, and these are all published papers, by the way. So this model is about HIV. I don't know if you can see. This is having, I can't see it myself. So, yeah, it has a gender. It has a gender into it. It has risk categories. There are some people who are high risk of HIV, like sex workers. There are very high rates of infection among them. So they are high risk. And then there are even truck drivers are also considered very high risk. And then there are antiretrovirals. Antiretrovirals are the treatment given to the HIV patients, and they are given to maintain the level of infection in the body. So once the infection goes beyond a certain level, they give a treatment, and it goes on. And once the virus count decreases to certain levels, you stop the treatment. That's the goal, because the treatment has side effects, major side effects. So the goal is to maintain the virus level below. You cannot eliminate the virus. Once the person is infected, you cannot eliminate it. Okay. So then it is maintained for some time, and you stop the treatment because you want to control the side effects also. And so then the virus comes back, and then you give and maintain the infection, give the treatment again, and maintain the level of the count. So this is how it works in HIV patients. Now, what is the problem with HIV patient? Why can't you control the infection? Because it goes in the stem cells, and it goes to the places where you cannot eradicate from. But there is a way to eradicate it, is by usually it is by pre-exposure prophylaxis. It's a type of a vaccine, not a vaccine, but it is given to the patients who are not yet infected. So you take it as a pill every day. And the hope is it is given actually to a high risk group, like sex workers. They take it as a treatment in a high prevalent countries. They take it every day as a pill. Why they take it? Because typically when HIV person gets infected with HIV, there is a short window period in which the treatment if given could cure. So for example, nurses in the hospital settings gets the PrEP. Sometimes by mistake they get the infection into their body by treating a patient. So they get this emergency treatment in a medical settings. But window period is very small, very, very small. If you do not get the treatment within that infection establish itself in the body, and you cannot treat it with antiretroviral. See how complex it is. So therefore there is a PrEP, pre-exposure prophylaxis, is a treatment given as a tablet every day. But this is, if you give more treatment in the population, what happens? You say, oh, there is a treatment, why don't we give it to everyone? No, you cannot. Why not?
Economic issues. You have to spend a lot of money on it.
Say again?
You have to spend a lot of money on it.
Okay. Suppose I have infinite amount of money, then?
There will be hysteria among people as well.
They have what?
Hysteria among people.
They will not take it.
Yes.
Is that what you are saying?
Yes.
Behavior issues?
Yes.
Okay. Suppose behavior issues is not an issue, then there is no problem. You should give it to everyone then.
It will have side effects maybe.
Well, side effects are there, but still you will completely wipe out the disease. HIV will not be there anymore in the population if you do that. But why you don't do it? First of all, this will take a long time, even if you do something like that. Second is the drug resistance. Because if you give the treatment, there will be a lot more drug resistance cases. You are putting drug pressure in the population a lot. This is a balance you do it as a public health policy makers. You don't want to give too much drug in the population. What is the problem with the drug resistance? What is the problem? What does drug resistance means? The drug is not working in a patient. Resistance means drug is not working in a patient. That drug is meant for that patient and that drug is not working. And what is the bad thing about it? Oh, it is not working, of course, for that patient. But that patient is just single person. That's okay. But the problem is you have discovered this treatment for last 60 years of research and you got one pill. And now you spoil that 60 years of research with making the drug as a resistant. Once it becomes resistance, it will spread. Resistance will spread in the population. And it will spoil the treatment for everyone. So you don't give the treatment, you don't give a treatment like that to everyone. So that's the issue with HIV. I mean this drug. So there is a trade-off. Benefit of giving more treatment, but also what is the benefit? You are curing more people. But you maintain that cure rate in such a way that a resistance is not. So modeling is very, very key aspect in this area. Okay, so I think I will stop here. Vaccine this is with Dr. Jayaprakash, who will be talking very soon. Trivedi and anyone else there? No, I think this is the one only. And okay, I think I will stop here. And I think this is fine, and this is a good place to stop. I will be talking about how to analyze a model in the next class, and then in the afternoon we will do some hands-on work in that. Okay, so let's go and have a tea.